Hello, everybody, and welcome back to the Technologies in TBI mini-series. I hope you're enjoying this series, and I hope you're learning a lot from it and learning a lot about what functional neurology is and how specifically we practice in Minnetonka here, and the things that we can do for you and your loved ones if you're struggling with things that we work with. So, again, my name is Dr. Matthew Shim, and today what I'm going to be talking about is oculomotor function, which is a really big proponent of the therapies and the assessments that we do here in the office because the eyes are such a critical role, or they play such a critical role in brain injury, and that's a heavy percentage of what we see here in the office is brain injuries. And the reason that they're so important is because the machinery involved with oculomotor function and moving the eyes around are so vast in the brain and require so many different regions in the brain that based on little things, like we talked about the first day, based on just seeing these little bitty changes, we can point the area of dysfunction in different regions. And so, um, if you have any questions, please just drop them below, and either myself or one of the other doctors will come on here later on Facebook Live and we'll start answering some questions. So I hope you enjoy it. And here we go. So the first thing we're going to talk about is just pretty much what the eyes do and what we're really looking for. So like I told you the first day, whenever we talked about BNG and the goggles that we put on to assess different eye movements, we kind of kept it superficial. So this one's going to go a little bit deeper, but not too deep to like really blow over your head. So what you need to know about the eyes is we have two of them. There's 6 muscles around each eye that coordinate movement of the eyes in different directions. And the things that we're looking for whenever we're looking at the eye movements is how fast are they moving? How accurate are they moving from target to target? How long does it take for you to initiate moving from target A to target B? What is the position of the eyes relative to the other eye? And then we'll go through the different tests. But why this is important, let's start with speed, at least. So speed, we talked about it in my last talk on dysautonomia and the autonomic nervous system. And we may have touched it on the VNG, but since we're in oculomotor function, let's just touch on it again and saying that it's important for your eyes to be quick and accurate. So let's just talk about speed first. And a lot of times what we see in concussion and what I've saw a number of times over the last few weeks, and specifically there's one patient that comes to mind, is this little girl who she had a brain injury while during a swimming event, and she had a complaint of just feeling kind of off, kind of dizzy, lightheaded. And whenever we put her on the goggles and watched her eye movements, whenever we watched her pursuits, which is where you're just following a target going smoothly left and right, ideally your eyes should just be locked on that target and smoothly trace that target. Well, with her eyes were really jerky. And so I asked her, I said, do you ever experience moments where you feel like you don't really know where you are? And more specifically, you don't really know where your head is? And she said, yeah, absolutely, all the time. And I've been told by so many doctors before that I'm just crazy. And I explained to her from there that based on this one test here, it makes complete sense on why you would experience that, because in the brainstem, in the vestibular nuclei, we have these other little nuclei called PVP neurons, or position vestibular pause neurons. And basically what those neurons do is they give us a position of where our head is and where our eyes are located in space, because humans are designed to move. And in order to move, we first have to know where you are. So for example, if I want to reach out and grab my water bottle, I first have to know where my arm is so that I can coordinate muscles appropriately to get to my water bottle. Because if my arm's over here versus my arm's over here, my muscles are going to coordinate a little bit differently to get to that final destination. It's the same thing like if we get in the car and we want to go to the supermarket. If I put in the destination to the supermarket, but I don't have the current location that I'm at, I'm never going to get there. It's the same thing with the brain and the human nervous system, because the human nervous system has a couple different sensory systems that is always answering the fundamental question of where am I located in space. Humans are designed to move, so it's very important for us to know where we are. And so to tie back into the speed of the eye movements, we have to have those quick, because a quick jerk of the eyes, or me looking from here to here, to do that quickly during that time frame that you're doing a circad is what it's called. During that time frame, you're inhibiting the PVP neurons. So during that time that your eyes are jerking, you don't really know where your head is. So do you see how it's advantageous to have a quick saccade and quick jerks of the eye? Because if they take longer, that's a longer span of time that I don't know what my head is. And in reality, we're talking about milliseconds, but in the brain's world, milliseconds is a long, long time. So then from there, we move on to accuracy. And we're looking at, whenever my eyes jump from here to here, how many steps does it take me to get to that target? Ideally, what it should take is one single jerk, one single jump from here to here. And what we see a lot of times with concussion is these pathways get disrupted, especially because they're very midline, they're very long, where they come down from the cortex, they pass over and cross over, and they integrate in the brainstem. And since they're so long and right in the middle, they're very susceptible to damage whenever you have whiplash injury or concussion, where the brain is torquing and causing shear force on the brainstem. And so in regards to accuracy, ideally what I want is here to here in one quick movement. But a lot of times what we'll see is somebody will do 2 or 3 steps to get there. Well, they'll jump a little bit short, and then they have to re-saccade to get to the target. And so it takes them 2 or 3 times to get there. Or what can happen is they overshoot the target and then they have to shoot back. So it's just a poor coordination of planning. And oftentimes, we also see, remember we talked about the spontaneous nystagmus testing, where we put you in the goggles, we put you in the dark, and we see how your eyes move in the dark when we don't want anything. Ideally, we want your eyes to be rock solid. But whenever you have things like that, where your eyes are jerking around the dark, or you have nystagmus, it makes it a lot harder for you to be able to coordinate activities of accurately saccading to a certain target, because your eyes are always moving. So you see how much more difficult it is for the eyes to be able to coordinate appropriately how to get from point A to point B in one step whenever the eyes are constantly moving. So if my arm's constantly moving and then I try to reach out to my bottle, it's going to be a little bit more difficult if my arm's steady and then I go and reach out. So something that ties into that very heavily is people with poor oculomotor function or poor accuracy in oculomotor function experience a lot of fatigue a lot of times, where they'll have, if I'm jumping my eyes from here to here, and if typically what should happen is I just go from here to here in one step, but now I'm doing 3, 4, 5 different saccades just to get to this one target, I'm using up a lot more resources to get a job done that should only require a little bit of resources. So if you think about it in the terms of fuel allocation, if I have 5 gallons of fuel to use in any given day to accomplish my daily life, and ideally only 1 gallon of that 5 gallons should be allocated towards moving my eyes. And now if I'm having to do 2 or 3 or 4 times as much work for my eyes to get from one target to the next, do you see how you can run through your resources a lot quicker and then want to crash earlier in the day? And so that's how oculomotor function and accuracy can tie into these different symptoms that we see. And then latency. whenever we look at latency, we're looking at how long does it actually take for you to initiate going from, if I'm looking here and I wiggle this thumb, I want to be able to go to this one as quick as I can, but how long does it take you to actually engage and take your eyes from this one to this one? So it's another important thing. And then whenever we look at alignment, a lot of times in concussion, we see where the two eyes aren't looking in the same direction. And that's important because if you think about both of your eyes like two cameras, and for you to experience the majesty of this world and see clear, crisp vision, ideally what we want is for both of your eyes, both of your cameras to be looking at the same exact target at the same exact time. But a lot of times in concussion, that's not what happens. And what we can have is one eye will be in, one eye will be out, one eye will be up, one eye will be down relative to the other eye. And whenever you may have heard the lazy eye terminology, but that can be an accurate claim, but oftentimes in concussion, it's so minuscule that you don't notice. It's not like you have an eye that's way over here. It's just a little bitty, tiny difference. And so how we can pull it out is if, let's say that this eye is not looking, if I'm looking right at you and I cover this eye, but my right eye is a little bit off, what we'll be able to see is whenever I cover this one refixates and it'll move back down. So let's say this eye's a little bit out. If I cover this eye's going to come in. If then I can do different tests like that. It's called cover and uncover test, where we can basically look and see, and then also in the VNG testing, we can look and see where the different lights are in the eyes and see different rotation of the globe or of the eye and see if it's gone in a different direction. And why that's important is because, again, based on how we see an eye up or an eye down or associated head tilt, we can localize different areas in the brainstem that are off. But also, just coming from a pure visual perspective, is all it takes is 2 degrees for one eye to be off in a different direction, for your visual acuity to drop 50% and you to experience double vision. That's all it takes is 2 degrees. Anything under that, but not quite 0 degrees, so anything between 0 and 2 degrees, you can have blurry vision. And that's what we see a lot of times. It's very common for people to have blurry vision and their vision is not as crisp. And that's because both of their cameras aren't looking at the same thing. So imagine if I have one image from this eye and a little bit different of an image on this eye, and they try to overlap. But the only way for you to have crisp, clearer vision is both of those images are the same. So we have a slight different image and then you get blurry vision, or maybe you're watching my thumb go by and you can tell that my thumb just gets a little bit wider as we go across and things like that. So then as we jump into the different tests that we do, first one was at least bedside. What we'll do is we'll look at gaze fixation. We'll look at your ability to hold steady on my thumb and center and right and left and up and down, and just look how good or how intact is your ability to hold steady on a target. And we're looking for different things that take your gaze off of the target. And so, like, let's say we go over to the right and we see your eyes drift slowly back in and then beat back out. That's going to tell us something completely different compared to if I have you go over here and my eyes jerk a little further than the target and then jerk back. It's all telling us little bitty different things. And then as we go from gaze fixation, we'll go into pursuits. And we'll just move our thumb slowly back and forth, and you'll follow it. And ideally, what we want to see is your eyes just smoothly track back and forth. Again, we're trying to look for jerks of the eyes. We're looking for alignment of the eye. So let's say whenever I come over here, my right eye comes up, and then whenever I go over here to the left, my eyes level out. So we can look at the different integrity of the muscles of the eye, where if I move it out here and I bias a different eye muscle compared to whenever I go to the left, we can localize and say this eye muscle over here is not really as strong as the one over here. And we can do different exercises to try and activate those different muscles and get them stronger. And then from there, we're going to look at cycads, or your ability to look for the target quick. And bedside, what we want is we're going to look at speed and accuracy and latency. And with cycads, bedside at least, whenever we're looking at cycads, we want them to be so quick that we can't even see them get there. Okay, if we can see the eyeball move, it's too slow. And then we're looking at how accurate are you on my thumb? And we can do different things where we could do like sound-based cycads or memory cycads or anti-cycads, things like that, where let's say if I close my eyes and I snap and I open up my eyes on where I think the sound was, or I could do anti-cycads where I look at your nose in front of me. Whenever you wiggle your thumb, I look at the opposite one. That's incorporating a more of a dorsal lateral prefrontal cortex mechanism and being able to shut down the urge to want to look at the one that wiggled and look at the opposite one, or memory cycads, where we can use something like Focus Builder that I think will also be on this series, or this technology and TBI mini series. And you're going to get to listen to one of the founders of Focus Builder, Dr. Cedric Noel. And we can do things like give you a series of 4, 5, 6, 12 dots and tell you and have you memorize which ones were on, or in which order they came on in a sequence. And it's all looking at different areas of the brain and helping us again localize the most important area that we need to focus on in order to get you better. And then from there, what we're going to go into is VOR testing. And what VOR is your vestibulo-ocular reflex. Your vestibulo-ocular reflex is the ability for me to keep my eyes steady whenever I shift my head. So if I shift my head to the right, ideally my eyes should come back to the left. If I go to the left, my eyes should come back to the right. Up, down, same thing. And a lot of times in concussion, we see that this mechanism isn't working right. And so you could have anywhere from a peripheral vestibular dysfunction all the way into the central connections in the brain and the brain stem and the vestibular nuclei. So again, it's all a game of localization of where is the problem. And whenever I think about this, I think about one gentleman in specific that I probably saw about a month ago, where he, over the summer growing up, he said that he was an avid wakeboarder, and he was out there every day during the summer, took a lot of spills, got 2 major concussions that he can think of, but he was wiping out every single day. So maybe he was experiencing subconcussive blows and just causing a lot of damage to his noggin over time. And now what he's experiencing is if he's now into mountain biking, and whenever he's on that rough terrain, the perturbations of being on the rocks and the different rough road causes his head to move. And in order for me to maintain clear, crisp vision, my eyes need to move in the opposite direction. Same thing when I'm walking, is whenever I'm walking, my heel hits the ground and it causes a shock wave to go up through my body that's anywhere between 0.5 to 5 hertz. And what my brain should be able to do is detect that shock wave and move my eyes in the appropriate direction, opposite that perturbation, to be able to keep clear, crisp vision. And with this gentleman, is his VOR reflex wasn't really like that crisp. And so what happened was, whenever he's bobbing up and down on his bicycle and on that rough terrain, his eyes aren't able to keep up, and he gets really dizzy and he gets really lightheaded and things like that. So then we have to go in and rehab that for him specifically, but for you, it may be a completely different case. And then lastly, whenever we're looking at optokinetic function and we're looking at it bedside, what we're going to look at is optokinetics. And you may have seen this, where we have these tapes that are red and white stripes, and we'll just drag it across in front of you. And it's just a reflex. It's an optokinetic reflex where you shouldn't have to think about it. And as we drag the red and white tape across you, your eyes should pick up every single red target as it passes in front of you. And basically, you're going to be on a target. You'll watch as it passes by. And then as your eyes drift out so far, your brain's going to say, oh, I'm not looking at the center anymore. Jerk back to center. So you'll get what we call nystagmus. And a lot of times in concussion, we'll see where the nystagmus isn't good. Or what I've seen more often than not lately is the optokinetic reflex is good, but it causes the patient to experience a lot of symptoms. So why would that be? Imagine this. If you're sitting in front of me and you move to my left, how does my brain know that it was you moving to my left versus me shifting to my right? And I'll tell you that the way that the brain knows that is because if I see my visual environment shift one direction, my brain then has to get feedback from my muscles and joints and from my vestibular system saying, well, I didn't feel us move. I didn't move. So it had to have been the visual environment move. Or let's say I see the environment move to my left, but my brain says, or my vestibular system says, yeah, I felt a shift over towards the right. Then it was probably me moving versus the environment. And then we can work through those different situations, or we can work and say, well, we probably both of us moved because it's not the appropriate response that I was expecting to see if one thing moved and I moved. So it's a constant battle in this redundant sensory information to know, where am I, where are things around me. And that's the most fundamental question that the brain is constantly asking. And that's one of the most fundamental questions that we ask in the office during the exam with different tests. We're basically just asking the brain, do you know where this is? Do you know where this is? And then we'll use different therapies to say, okay, this is how we incorporate a better understanding of where we are in space. So from there, that was all basically a better understanding of what it is that we're looking for and the different tests that we use bedside. And then going further into the assessment tools that we use here at the FNC is just the same things that we talked about earlier in the week with the diagnostic equipment talk the very first day. So obviously we have the VNG, and I think this is just an incredible piece of technology, as this picture that we have here with this gentleman in the goggles. And basically what we're doing is he's sitting, an arm distance or two away from the TV. And have these goggles on where we can record what his eyes are doing and show him what is happening with his eyes whenever we go through different tests. And like I mentioned the first day, I'm a big, big, big fan of all this diagnostic equipment, especially the VNG, because I'm a very big proponent of patient education. I think patient education is so, so important, especially with the work that we do, because a lot of times what we see is patients come, the last couple of patients I've seen, they come in with like 3 or 5 inch binders of the different providers and all the tests that they've ran, but they still don't understand why it is that they're dealing with what they're dealing with. So to be able to tie in those questions and make everything make sense and have the patient go, oh, that makes sense. I live for those moments. Obviously, right behind the moment whenever they're leaving and they're saying, man, I can't believe how great I'm doing. All these different testimonials that we get, those are why we do what we do. But it's also moments like this where things click for them and they understand why it is that they have this and why we're choosing to do the therapies that we're doing. I think it just makes for such a better encounter with the patient, and they're so much more invested in their care. And it also puts a little bit more of a strain on me to make sure that I'm doing my job, because if I show you on day one that this is what your eyes look like, this is what I want to get them to look like, this is why you're dealing with what you're dealing with, and if we don't fix this, you're probably going to have the same symptoms. And then we come back on day 5 and we rerun these tests, or maybe day 3 or 4, and we rerun these tests, and I show you the eyes. I can't just tell you, yep, that looks better, when you can clearly see the results in front of you. And we can go back and forth and compare the first day to the second assessment, re-exam, and we can show you that this looks better than this. So it makes me have to strive a little bit harder, because I can't just say, yeah, this looks better, but maybe you don't feel better. Obviously, we're always monitoring objective and subjective tools, or subjective and objective measures, because not only is it important to get these different objective findings better, but I want you to feel better. And so this is just one of the tools, or a couple of the tools here, that we use to monitor those objective things. So from there, from VNG, we then go to cycadometer. And what that is we put this little device on your forehead, and it's got little lasers that shoot out. So you'll sit like an arm's distance away from the wall, and it'll shoot little lasers out in front. And you'll basically look at the lasers as they pop up. And what it does is records the accuracy, the velocity, the latency of your eye movements. And we can do that on day 1 again, and then day 5, and see objectively what the benefit, or what the gain has been, or what the success has been over the week here. So then we go into right eye. And again, it's kind of just like another test, like the VNG, but it gives us a little bit better of a printout, because patients really like it. And it gives you a score. So patients really like, whenever they come in, they get a score of 37, and then they leave with a score of 73 or whatever, And so it prints off pretty little graphs that patients really like. And so I really like it. 2, I think it's a good combination of all these different things for patient education, but also assessment tools, and saying, this is what you look like the first day, this is what you look like on the last day, and these are the gains that we've made over the week. And then obviously the bedside examination is kind of king over everything, where we then compare all of our VNG, cycadometer, right eye findings, and hopefully they should match up. And then whenever we come into the bedside examination, that should match up as well. And then we'll sit down and write up a treatment plan catered specifically to you and your needs, to try and get you better as quick as possible, by utilizing all these different tools in order to best localize the area of dysfunction in your brain. So again, I hope you enjoyed this talk. If you have any questions, please just drop them below. And I think I have a couple more talks with you, so I look forward to those. Other than that, I hope you have a great day. See you soon.